But I just wanted to say good afternoon and thank you very much for joining us today for our annual breast cancer awareness session here at Seven Insurance Broker. So if I haven't met you already, my name's Laura and I'm the Health and Wellness Manager. So I'm pleased to see you all join and still all coming in, which is great. And whether you're tuning in live or watching this recording later, thank you for joining us. So this session is always one of the highlights of our wellness calendar, and it's our chance for us to really come together to learn and reflect on the importance of early detection, self-awareness and support as well. So I'm absolutely delighted to welcome Dr. Dana, who I've had the pleasure of working with for many years. And I'm also so happy and pleased to tell you that she's also my doctor. So a little personal note, a while ago when I was seeing Dr. Dana, she did detect a very, very slightly abnormal area in one of my breasts. She was absolutely fantastic, monitored it so closely, and thankfully all has turned out to be clear. But on the basis of that, one of the reasons why I wanted to share it is because it really does remind us of how important these regular checkups are and how important they are to be done with trusted medical guidance as well. So every time Dr. Dana joins us for one of these sessions, I'm also reminded why these sessions are so special, and it's her depth of knowledge and her compassion, but also her practical advice that makes these conversations both engaging, but also really empowering. So today, I'm sure she's going to tell you exactly what's going to happen, but she'll be guiding us through some of the latest insights on breast awareness, including prevention and screenings, and the small steps you can take as well to protect yourself, and how also to support others. So please feel free to drop your questions into the chat box if you have any, and we'll be sure to answer them all at the end of the session. But without further ado, thank you very much, Dr. Dana, and I am going to hand over to you.
Thank you, Laura. Thank you so much for that lovely introduction. And I just want to say it's a privilege to be able to care for you. You make it also very easy. So it goes both ways. And thank you, everybody, so much for being here. And I hope you take something useful out of this talk today. It's a topic just very close to my heart, and I'm very, very passionate about it. All right. So I think most of us in the breast field, whether you're a radiologist, a surgeon, or even a medical health professional, our vision really is a world without breast cancer. And so today we'll be talking about some statistics regarding the topic, which kind of highlights why we dedicate a whole month of the year to this. We'll be discussing what breast cancer actually is, what it means to be breast self-aware and how you can protect yourself. My favorite topic as a radiologist, which is how you can screen yourself and screen your breasts. And we'll touch very briefly on treatment, support, and resources. So I want to stop for a second here and ask you all, when you hear the term breast cancer, what does it actually mean to you? Have you yourself been through a diagnosis, or have you known a friend who has gone through it, or even somebody who's had a scare? What does breast cancer mean to you? And I also want to ask you, what do your breasts mean to you? I think a lot of us don't really stop to think about that question, but for a woman who might be facing losing part of their breast or their whole breast, this question becomes a very, very important and valid one. And you can see here on the left side of the screen, this is the Lebanese singer Elisa. She was diagnosed with breast cancer, and she's been a huge advocate in the Middle East now for breast cancer awareness, and especially in our region when topics such as these tend to be filled with stigma, shame, and taboo. And on the right side of the screen, you can see Angelina Jolie. She was diagnosed with the BRCA gene mutation, which predisposes her to having higher risk of developing breast cancer over her lifetime. And she was also very open about it. Her mother died of breast cancer, and so she elected to actually have what we call a prophylactic mastectomy, which is removal of both breasts to prevent breast cancer from actually happening. So you can see from east to west, breast cancer is a global problem. So somewhere in the world, a case of breast cancer is diagnosed every 19 seconds. So you can imagine how many cases have been diagnosed just in the time that we've been talking just now. And a woman unfortunately dies from breast cancer every 60 seconds, even though our treatments have advanced so much that if it's caught early, it's completely curable. And over the next 25 years, another 42 million cases are expected, and another, unfortunately, 13 million women will die from this completely preventable disease. So what about compared to other cancers? So in the world, the incidence or the number of times breast cancer is diagnosed, it's the #1 diagnosed cancer. And that's even if you include men in the equation, it's still the #1 diagnosed cancer. And also, unfortunately, the #1 cause of cancer-related death. Well, okay, we know that it's a global problem, but is it a problem in the GCC region? Well, yes, the incidence is actually rising over time in the GCC and the Middle East. And then what about in the UAE? Okay, we know it's a problem in the GCC, but is it a problem in the UAE? Well, yes, it's the #1 diagnosed cancer in the UAE. Even when you include men in the population, it's 22.4% of all cancer cases. And then when you look at women alone, it's 40% of all cancer cases. So #1 diagnosed cancer globally in the GCC and also here in our community in the UAE. The incidence is also rising in the UAE over time rapidly. But what's really important that I want to highlight is the average age of diagnosis in the UAE is between the ages of 40 to 44, which is a very, very young age. Well, what about men? Can men develop breast cancer? Well, yes, up to 1% of cases can actually occur in men. And it's important for men to understand that if they have a strong family history, they could be at higher risk. And they could also carry gene mutations that they can actually pass on to their children. So men also need to be aware of this. So I'm sure all of you are asking, well, why is breast cancer actually rising in the GCC? Well, there's a lot of different theories. It could be changing lifestyle and increased obesity, delayed childbearing or fewer pregnancies. So we're having fewer children and we're having them later and later or no children. Urbanization and environmental factors. And then also counterintuitively, because we're screening more and we're catching cancers earlier and earlier, there's something called a lead time bias. So it could artificially increase the numbers for a little period of time. But even when you try to control for this, the incidence is rising. So what is breast cancer? What are we even talking about here? Well, breast cancer starts with a single cell. And what happens is that cell undergoes a gene mutation. It starts growing uncontrollably. It starts taking over normal, healthy tissue around it. And if you leave it unchecked, then...
Hey, Dr. Dana, so sorry to jump in right here. I think you might have muted yourself. There we go. There you go. I'm not sure how that happened.
How long did that go on for? I'm so sorry.
Just literally like the slide before, just a little bit towards the end.
Perfect. No. I'm so sorry. I don't know what I did here.
No,
so I'm not tech savvy either.
No worries. Thank you.
All right. Thank you so much. Okay. So when we're actually looking at breasts, what are we actually looking at, or what parts of the breast matter? So the breasts are mainly fat and breast tissue. And what we really look for are the what we call the lobules of the breast. So the lobules are like the milk producing factories. And then we also look at the ducts, which carry the milk from the lobules or the factories to the nipple. And then the rest of the breast is made up of fat and suspensory ligaments that basically kind of keep everything together. And as we all know, we undergo so many changes over our lifetime, including our breasts, from puberty to menstrual cycle to pregnancy and postmenopause. So many changes occur in the breasts over a lifetime. So what about genetics and breast cancer? So as we discussed, usually it's just a single cell that undergoes a gene mutation. Most of these gene mutations are sporadic, or they happen just out of nowhere. And then some of them are due to an inherited gene mutation, like the BRCA1 and 2 that, for example, Angelina Jolie was diagnosed with. But what's really important to understand is that inherited mutations associated with breast cancer only comprise about 5 to 10% of cases. Most breast cancers diagnosed are not due to known inherited gene mutations. And in fact, 75% of women who develop breast cancer don't have a family history at all. So for any woman out there who thinks, well, I don't have a family history, so this isn't going to affect me, just very important to understand that it can affect all of us, even if we don't have a family history. Also important to know that breast cancer is not just one disease, it's a family of diseases depending on the type of cell it affects. So the most commonly diagnosed breast cancer is something called invasive ductal carcinoma. So it's cancer of the ducts. And then less commonly, there's invasive lobular carcinoma, which is cancer of those milk producing factories that we were just talking about. And then there's some others as well that are much less common. But the good news is if there is a change in your breast, don't panic and automatically think that it's something really, really serious, but just please make sure you go get it checked because most changes are actually benign. They're not cancer. So things that can be found in the breast are fibroadenomas, for example, or cysts, which are just water balls, or benign calcifications that we see on a mammogram. So most changes in the breast are benign. So important to understand this. The point of awareness and breast cancer awareness isn't to scare women or it's not fear mongering. You know, the idea is just to be aware that if there is a change in the breast, just please go get it checked and make sure that it's nothing more serious. All right, so we've talked about some scary statistics and kind of learned a little bit more about the breasts. So what can you actually do to protect yourself and what does it mean to be breast self-aware? So breast self-awareness comprises four main pillars: knowing what your risk for developing breast cancer is, knowing what is normal for you, getting screened, and making healthy lifestyle choices. So I want to stop here and ask you, what have you heard in your community about the factors that actually increase the risk for breast cancer? So if you guys want, you can put some of your comments in the chat and we can maybe look at them at the end of the presentation. But what have you actually heard in the community? For example, have you heard that mammograms cause cancer or deodorants cause cancer, underwire bras? What have you heard in your community about what increases the risk of breast cancer? So if you want to put it in the chat box and we can have a look at the end. All right, so the top two risk factors for developing breast cancer is being female and getting older. So I'm sure that's surprising to a lot of you, but unfortunately, these are factors that really are not in our hand and we can't control. So breast cancer really can literally affect any of us. But there are some factors that might increase the risk for a woman. So for example, having a family history might increase your risk. Being overweight or obese after menopause, consuming large amounts of alcohol. In the past, hormone replacement therapy was thought to maybe increase the risk, but the newer studies are showing that that actually is most likely not the case. And also the newer HRTs right now are very bioidentical. So what I usually tell patients is if you're on HRT, take it if it's helping your symptoms, but just please make sure that you get screened appropriately for your breasts and also the uterus. Also, having children after the age of 30, that's completely normal in today's world. But biologically speaking, the later you have your first child or the earlier you have your period, the higher levels of the hormone estrogen you're exposed to. So the idea here is that we believe estrogen is the main driver for breast cancer, and the higher levels for a longer period of time at younger ages could predispose you to being higher risk. And even being taller than average is a risk factor. So that again has to do with the hormone estrogen. It just means that you were exposed for higher levels of estrogen for longer because your bone plates fused a bit later. So even being taller than average is a risk factor. So how do you know your own risk? Well, you need to talk to your mom and your dad's side of the families if you can about your health history, and also talk to a doctor or a breast radiologist such as myself to get a risk assessment done. And we'll talk about a little bit more about risk assessments in the next few slides, actually. All right. The second part of being breast self-aware is knowing what is normal for you. So knowing how your breasts look and feel. And it's totally normal and okay to look at your breasts and check your breasts, usually once a month in the shower after period time, if you're still having your period. And the idea is that you should try to know your own body so well that any change in the breast, you can actually get it checked and report it to your doctor. You and your doctor are your best chance of finding things as early as possible. But it is such a taboo subject. A lot of women feel shame or feel that it's wrong to look at the breasts or feel the breasts, but it is totally okay, normal, and actually very important to make sure you check yourself once a month and know your own body. So what are you looking for when you're checking your breasts? Any itchy, scaly nipples or rash on the nipple, any pulling in of the nipple or other parts of the breast, nipple discharge, for example, that starts suddenly or it's bloody or clear. And also any new pain in one particular spot that doesn't go away. So breast pain is very normal. A lot of us have had breast pain, and usually it's related to some hormonal fluctuations. But if it's in one particular area not going away, then please get it checked. I'm sorry, there's one slide missing here, but there are other parts to look for as well. Lumps or bumps, any dimpling or hard areas in the skin, any redness of the skin, although this could be an infection or an inflammation. It could be also something called inflammatory breast cancer. So these are things to also look out for when you are checking yourself once a month. All right, going back to the risk assessment. So every woman who walks through our door gets a risk assessment. We usually use something called the Tyrer-Cuzick model. This is the software. We're going to ask your age, when you had your first period, your height, your weight, etc. A lot of different questions. When you had your first child, menopausal status, also mammographic density. So we will actually assess this, and I'll show you pictures of what that means. And also family history. So very, very comprehensive risk assessment. And then at the end, it will give us a lifetime risk for you. So the magic number usually they say is 1 in 8 women, right? 1 in 8 women will develop breast cancer over their lifetime. So that's an average risk of almost 13%. So if your risk is 15% or lower, then your kind of average risk, I don't like to use the word low, but it's average risk. If the lifetime risk is 15 to 20%, then you're considered intermediate risk. And then if it's more than 20% lifetime risk, then you are considered at higher risk for developing breast cancer. So also making healthy lifestyle choices. Try to maintain a healthy weight, add exercise into your routine, limit alcohol use and menopausal hormonal use if you can, although again, the dogma is shifting with this. And also breastfeeding is very protective. Usually I don't like how much pressure women are under to breastfeed. I think just try to breastfeed if you can, as long as you can. But if it's difficult, you have a career, etc., don't be too harsh on yourself to try to breastfeed. But if you can, it is definitely what's best for mom and baby. And I also want to just stop here and take a moment to say that, you know, I think as women, we are very, very good at blaming ourselves for things that are not in our control, or they're out of our hands. And so if a woman developed breast cancer, it's not their fault. But what we're talking about here are some factors that are in your control that you could try to practice in order to lessen your risk for developing breast cancer. And it's also good in general for your overall health. All right, so now getting to our favorite topic, which is screening. I hope everyone's doing okay out there and learning something a little bit new that you can actually take home with you. All right, so what does it mean to actually screen the breast? Well, a screening starts with a clinical breast exam. It's usually done by a doctor or an OBGYN or a breast surgeon. And we usually recommend starting it at the age of 20 every 3 years, and then every year starting at the age of 40. And that's if you're average risk. If you were at higher risk, you may actually need to start your screening a bit earlier, and I will show you some of the recommendations for that. So screening tests are offered to women who don't have a problem. So you don't have to actually have a finding or a problem in the breast before getting your mammogram or an ultrasound. These are different from diagnostic tests where there is a problem and we're checking or problem solving it. And some of the imaging modalities that we use for the breast include ultrasound, mammography, and MRI. These are kind of our main tools at the moment. So going back to that risk assessment, why is that important and useful? Well, it's because it guides us when we start screening you and with what tools. So if you were that lower average lifetime risk, we're going to start you on a mammogram at 40 years old. If you were intermediate risk, so 15 to 20% lifetime risk, then we may start the mammogram at 40, but also between the ages of 30 to 40. So for example, if a first degree relative was diagnosed at the age of 45, we may need to start screening you earlier at the age of 35. So this is also one of the really important factors why we need to know your family history and we need to know what your risk is. And then if you're at higher risk, more than 20%, this usually includes women who have BRCA gene mutations or other gene mutations, etc., or patients who've had, for example, external radiation to the chest as a young child for diagnoses such as lymphoma, etc. What really, really changes here is we will start doing a yearly MRI. So MRI is not offered to everybody. It's a very sensitive screening modality. I'll show you a picture of it and why it's important. And then the third aspect to this is adding ultrasound if you have something called dense breasts, which I also will show you a quick picture of. So this is what mammograms look like. I'm sure a lot of us have heard horror stories about how horrible mammograms are and how painful they are. But what I can tell you is if a mammogram is done correctly, it should never be painful. It's uncomfortable. It's not the funnest test, but it shouldn't be painful. And that's because we do need to compress the breast in order to open up the tissue. So what we will do is place the breast on a platform. And then we will compress the breast with another plate in order to open up the tissue on the inside. So on the right-hand side of the screen, you can see this is the picture that we take from the top. It's called a craniocaudal view. And the white in the picture is all of the fibroglandular tissue that we care about. This is what we really care about in the breast. The rest of the black is just fat in the breast. So you can see why we actually need to open up the tissue in order to make sure that nothing's actually hiding inside the breast. This is the side view of the breast. So we would take also a side view, an MLO view, and in order to actually see under the arms and get a 3D view of the breast. So this is what a 2D mammogram would look like. We also have something called a 3D mammogram or tomosynthesis. And the reason I'm telling you about this is now this is becoming standard of care. So if you can make sure that you get your mammogram done at a place that has a 3D mammogram or what we call tomosynthesis, then you're really, really advocating for yourself. And I'll show you why. So it basically takes a sweep across the breast and we can actually slice through the images at 1 millimeter interval so we can really see in between the tissue. So this is a real life case I had. You can see on the 2D mammogram, there's not much going on. Even for me as a breast radiologist who's been doing this 10 years, I can't detect any changes here. But when we did the tomosynthesis, which is slicing through the breast, within the outer part of that right breast, there was this little area that was pulling. It's something called architectural distortion. So this ended up being a tiny little cancer. The patient was treated and she was fine. And so again, this is a very good example of how a 3D mammogram is very useful, especially if you have a lot of the white compared to the black in your breast. So you have something called dense breasts. We also have fancier mammograms. I don't want to spend a lot of time on this, but you can see this breast is a little bit busier. She has a little bit more of the white compared to the dark in the breast. Difficult to find changes here, but on that right side of the breast, you can see something lighting up on the mammogram. So we inject contrast through the vein and then we do a subtraction image and I can actually detect something that's lighting up more than the rest of the tissue. So these are modalities that we can offer women who are intermediate or high risk that can't, for example, do an MRI, but it is available and it's available in Dubai as well. All right, so how about how often? How often should we actually screen? there's a lot of controversy about this. In the UK, for example, they start at 50, doing it every 2 to 3 years. In America, where I was trained, for example, we would the guidelines say starting at 40 and doing it yearly. And obviously I'm biased. I trained there and actually do believe that it should be done yearly, and the data doesn't lie. If you do it every other year, starting at the age of 50 to 74, then we save 23% of women. But if we do it yearly, starting at the age of 40 to 84, we save 40%. And also remember that in Dubai, the average age of diagnosis is between the age of 40 to 44. So we really do need to start screening women as early as possible. Well, a lot of women also are worried about the radiation dose from a mammogram. So if we do a yearly mammogram, is that going to cause cancer because of all the radiation? Well, no. The radiation dose from a mammogram is equivalent to a 6-hour flight. So when you're flying over to Europe for 6 hours, it's exactly the same dose. There are many, many studies that have been done about this, and there's absolutely no evidence to show that mammograms cause cancer. And in fact, mammograms save lives. So please, if you can get your mammogram at least starting at the age of 40 every year, then it's really the best thing that you can do for yourself. Because really the aim of the game is to try to find it before you even realize or know that it's occurring in the breast. We want to catch things as early as possible, or even in the pre-cancer phases, in the phases where there's maybe just atypical cells, nothing more serious than that. All right. This is a picture of breast density. So remember the density in the breast, it's the white compared to the dark. So half of us are actually fatty or scattered breasts, and half of us are what we call heterogeneously dense or extremely dense breast on the right side of the screen, where there's a lot of that white. So you can see that it's very, very difficult to find any major changes in these breasts when it's so busy. So what can we do? The reason I'm telling you about this, well, if we do a mammogram in a fatty breast, we would pick up 9 out of 10 cancers. But if we do it in an extremely dense breast, we'll pick up around 6 to 7 cancers. So what can we do about this is add an ultrasound. An ultrasound uses sound waves, and it's able to detect little masses that we may otherwise not be able to detect on a mammogram. Does it replace the mammogram? No, an ultrasound doesn't replace the mammogram, because mammogram sees things that we can otherwise not see on ultrasound, such as something called calcifications or distortion, like what we saw earlier in that case. So this is a real life case I had, a very, very dense breast. You can see very difficult to see any changes between old and new. But when I did her ultrasound, you can see she had an irregular hypoechoic mass at the 12 o'clock. So there's like an irregular mass that's darker than the rest of the breast. This turned out to be a little cancer. Patient was treated, and she's doing very well. So the power of ultrasound is very big. If you do have something called dense breasts and you're not offered an ultrasound, please advocate for yourself and make sure that you ask for an ultrasound. Just say, listen, I heard that an ultrasound is really useful for a woman like me with dense breasts. I would like an ultrasound. So this is the reason I'm showing you this, is because I want you to be able to advocate for yourselves and make sure that you get the screening that you actually need. It's not automatically offered at the moment. But for example, in the States, now it's law to offer an ultrasound in a woman who has dense breasts. So we're still getting there. All right, the last modality we have is that MRI that we sometimes offer to high-risk women or women who have more than a 20% lifetime risk. So you'll be kind of lying down in a machine, the breasts come down through a table, and you go through a tunnel. It is a longer exam. It does require contrast through the vein, but it is the most sensitive modality we have. I'll show you how. Another patient, really dense breasts, difficult to see any changes that are serious here, and a high family history. When I recommended an MRI, I found this little area that was lighting up in the inner side of her left breast. We biopsied that, and it ended up being a little cancer, only seen on MRI. So each modality kind of has its strengths and weaknesses. We don't offer MRI to everybody, but it is highest value in a woman who might be at higher risk for developing the condition. So putting that all together, if we do a mammogram, we pick up about 5 in 1,000 cancers. 5 in 1,000 cancers. It doesn't sound like a lot, but in a population with no problems, picking up 5 cancers in 1,000 is actually a very, very good screening test. It's one of the best that we have. If we add ultrasound, we'll pick up another 2 to 3, so we're up to 8. And if we add MRI, we pick up to 16 in 1,000 cancers. So again, each modality has its strengths and weaknesses. None replace the other. So what if there was a finding in the breast? Then we would need to take a biopsy, and they're usually very non-invasive. They're done in the office. We can do it just with local anesthetic. And it depends on the way we saw it. So you need a biopsy to make a final diagnosis. You can't just rely on the imaging. This is what it would look like to have an ultrasound biopsy. You'll be lying down on the bed. We give you local anesthetic or local numbing medicine. That's the worst part. You'll feel a pinch and a burn. And then we make a tiny opening and insert a device and take a couple of samples. If it's seen under mammogram, then we might do a mammogram guided biopsy. Some are lying down and some are sitting upright. And then if it's only seen on MRI, like that last patient we just saw, then we would do something called an MRI biopsy, an MRI guided biopsy. So it's important to know that breast cancer can be found at different stages. So obviously, if it's found earlier, it's definitely better, less treatment, less surgery, better outcomes. So I want to stop here and let you ask yourselves, if you or your family or friends have not been screened, why not? I really would love you to just ask yourself that question after knowing all of this information. Why not? Why aren't we getting screened? All right, I just want to very briefly touch on treatment for breast cancer. There's a lot of different options. If caught at stage 1 and 2, it's 99% curable. Surgical options include mastectomy, which is complete removal, lumpectomy, which is partial removal. And then there's also reconstructive options with an implant or a muscle flap, for example. And then if a woman undergoes a partial removal, then a woman is usually offered radiation therapy. And there's also systemic treatments like chemotherapy, hormone therapy, and biologic therapy. Again, the earlier we catch things, the better, because we might be able to avoid some of the systemic treatments for breast cancer. Okay, there's a lot of support for women undergoing the screening process. If you do come through the screening, let's say there was an abnormality, if it was investigated and fine, you just go into follow-up care. If breast cancer was diagnosed, then you would undergo treatment, follow-up care, and then you're back in the screening pool again. So it's a very, very robust continuum of care model. But then there's so many barriers to actually, for women to get a mammogram. So some language, for example, language barriers could be a problem. Older age, lack of access, financial issues, so many different barriers. But what I really want to touch on is the idea of fear, that a lot of women fear the mammogram, either because it's too uncomfortable or that it might cause cancer or that they don't want to know. But the real fear is when you don't get screened, because if you're getting screened regularly, even if, God forbid, there was a finding on the mammogram, we can totally deal with it and you're going to be fine. But the idea is to be screening at a regular interval. So the real fear is when you're not screening. Lots of resources in our community. You could be a leader in raising awareness for breast cancer. You can talk to your friends, coworkers, remind each other that we need to get screened and we need to check ourselves and share our experiences, and also just talk about it. Normalize the conversation in our community and in our culture. There's also support groups in the UAE. Breast Friends is amazing. Friends of Cancer Patients, Angels of Mercy. There are some support groups in the UAE as well for a lot of women. Okay, so just to review, breast cancer is a problem in our community. Please know your risk. Know what is normal for you. get screened and make healthy lifestyle choices. And I hope you share something you learned today with somebody that you care about. Thank you so much for your attention. How are we on time? Not too bad. Thank you so, so much. And this is my beautiful team in American Hospital Bersha. Love them all. Thank you.
Thank you so much for sharing that. I promise every time I listen to you speak, I learn something new. So it's wonderful to then be able to go out and, you know, have those conversations, open, honest conversations with people to bring that awareness. So thank you very much. In that, I do have to say I have had a mammogram, multiple, with Dr. Dana, and I do have to absolutely back up what she said. They're uncomfortable, but it didn't hurt. And again, I only have ever had them with you before, so I do have to say that. But yeah, if you're seeing the right people, I think that it shouldn't be a painful process as well. A few things on your earlier question, Dr. Jana, about the stipulation around what causes breast cancer. The two things that people dropped in the box there was smoking, and the other one is processed foods. What do you think if they are a contributing factor?
Yeah, so actually smoking is a controversial one. Obviously smoking is not good for our health in general, but it hasn't been a direct link between smoking and breast cancer. Smoking's been linked to lung cancer, pancreatic cancer, and bladder cancers. But there is a correlation between smoking and breast cancer. And obviously it's not a bad idea to not smoke. It's just good for your overall health and your heart health, obviously. But alcohol use, increased alcohol use, we're not talking moderation, we're talking large amounts, has definitely been linked to breast cancer. Processed foods, again, it's a theory, urbanization, environmental factors, processed foods, it is thought to contribute to cancers in general, but we don't have direct evidence for this.
Thank you. There was also another question here, and I think this is when you were talking about kind of the lumps and the bumps that we need to be aware of. And what happens if there is painful lumps under the armpit, you know, when it's that time of the month when you have your period, but then they go away? Is that something that you obviously need to track or keep an eye on, or what would your advice be?
So I think during period time, as we know, we undergo a lot of changes. The main change that happens is the hormones that are associated with the period. We get leaky, the vessels get leaky, and a lot of fluid kind of goes into the breast tissue. So we get a little swelling, tenderness, you know, we're a little bit more sensitive, etc. Cysts can also get bigger. So if you have, for example, water balls in the breast during period time, they can get larger. So you think that the cyst is actually getting larger, or the tissue around lumps are getting larger. So there's a lot of different changes. Under the arm, there are two things. So we can either have lymph nodes that might be a little bit enlarged. There's so many different reasons our lymph nodes can get a bit plumpy. For example, COVID vaccines, when we had COVID vaccinations, many women had enlarged lymph nodes under the certain arm that they got injected in, because the lymph nodes are working, trying to make the antibodies. It could be just reactive. You might be sick or stressed. There's so many different reasons that you get lumps or bumps under the arm. One other thing that can happen under the arm is some breast tissue can actually be under your arm. So we call it accessory breast tissue. And some women are born that way. They actually have that. So if you do feel a hard lump or something irregular under the arm, don't ignore it. Don't just assume it might just be, oh, I'm a bit tired, or it's a lymph node. You do need to go get it checked out. The good news is if it goes away, if you monitor it, let's say for a week, and it goes away, that's usually a good sign. Things that are serious don't normally just go away, but I still am a big proponent to just get it checked. Like if you did feel something, just go get it checked out, get a quick ultrasound, make sure that there's nothing in there, and you're good to go. But again, most of the changes in the breast are benign. They're benign.
Amazing, thank you. Another one, so if we were to do a self-check or a self-assessment, obviously that once a month after you finished your period is a good time. Obviously, for hormones are probably started to settle down, if that's correct. But where is the best place? Should we be laying down? Should we be standing up? Or is it kind of a combination? And I'm guessing then from the back of that comment, you know, we should also be checking under our arms as well. Is that right?
Absolutely. So very good question, Laura. So usually the kind of the quick way that I tell women, you can either do it lying down or in the shower, whatever you're most comfortable with. And what you're going to do is you're going to start with your hands on your hips and you're going to look in the mirror. So you have to look at the breasts, see how they look like. Your breasts are sisters. They're not twins. They're not supposed to look exactly alike. But if you notice, for example, one breast getting bigger or one breast getting smaller, then you need to go get that checked. Also, any redness on the skin, dimpling on the skin, any nipple changes, crusting of the nipple, don't ignore these. Once you've looked, you're going to raise your hand above your head for the side that you're going to check. And then you're going to use the flats of 3 fingers. And you're going to check from the chest wall towards the nipple in kind of small circular motions. And then once you're finished with the whole breast, you're going to check under the arm. Once you're checking under the arm, you're going to relax so that you can get your fingers deep inside the underarm area and check for anything swollen lymph nodes, masses, or any changes under there. So it literally takes less than 5 minutes. The more you do it, the better. You'll know your body more. At the beginning, you probably have no clue what you're feeling, or, it just takes a bit of practice, okay? But the idea is we want to detect changes in the breast. If there's a change, get it checked out.
Oh, that's amazing. That's great. Another question that's come in is how can you detect the difference between that kind of cyst and then glands, and especially when you're breastfeeding as well? Is, obviously a lot changes during breastfeeding, but is there any advice that you can give about how you can kind of what should be done differently or how to check?
It's difficult, even for me, who's a seasoned healthcare professional. And then, sometimes obviously if a patient comes in and tells me they're feeling something, I would examine them as well, just to make sure I understand what it is that they're feeling. But one way to differentiate is sometimes if it's a cyst, it's a little bit more what we call discrete, like you can actually feel the surface of it. And it's usually mobile. It kind of moves around with your hand, and it's smooth, mobile. And discrete. Mammary glands usually kind of tend to be islands of tissue, and they're kind of a little bit more global. They could also move around, by the way. It's not so easy to differentiate, but it's not as sort of discrete. You can't actually kind of tell me it's 2 centimeters. I feel like it's around 2 centimeters, or a coin size, or a pea size. But it's difficult. It takes practice. And if you're ever in doubt, just get a quick ultrasound. We can see a lot even when you're breastfeeding on ultrasound. So there's a lot of changes that happen.
That's amazing. Does anybody else have any other questions? Well, if you do, you obviously know where to direct your questions now. Dr. Dana's email address is under there, also her WhatsApp number, which is very kind of you to share. So thank you very much for that. I know, again, I enjoy these sessions so much, and it's a really important topic, obviously, to cover. But I just wanted to say thank you again so much for your time. What you do is very, very much appreciated. So thank you very much.
Thank you. And thank you for, raising awareness, Laura, and also, to everyone out there. I think it's really, really important topic, and I appreciate your support with this. Thank you for having me.
You're very welcome. Well, thank you, everybody. And like I said, if you've got any questions, please feel free to reach out. But I hope you all have a lovely day ahead. And don't forget to wear your pink badges for this month as well. Take care, everyone. Thank you.
Thank you so much. Goodbye. Have a great day.
Bye.
Thank you, Laura.
Thank you.